Hello everyone. Hi, it's been a minute. I apologize. I've had to take a little bit of a break in order to study, especially the internal medicine one. I was stressed, there's a ton of material, and I just did not get around to doing this video as soon as I would have liked to. And I decided not to do a vlog reel at the beginning of this one like I've done with other rotation review videos. And that's just because the day-to-day was pretty consistent. Not really a ton to video. But if you want me to bring that back for the next video, which will be the pediatrics rotation review, then I'll do that, no problem. So let's get into it. I'll tell you about my internal medicine rotation, one of the big ones, 8 weeks, just like all the previous videos about my rotations in my third year so far. These recaps are to give people who are coming up, soon gonna do these rotations, or are just curious about them, a good idea of what to expect in the rotation, what, one person's perspective was during the entirety of the rotation, what I learned, what the hours were like, the kind of exposure to different clinical practices that I got, yada, yada, et cetera, et cetera. And at the end, I'm gonna be giving kind of that spitball description of the types of people that I, saw that went into internal medicine. Because I think seeing the personalities that go into different specialties versus the stereotypes, I think that comparison is really interesting. And then also we're gonna talk about something super important, which is shelf review, especially for internal medicine. I don't think there is a single, if you're applying to residency, I don't think there's a single specialty out there that doesn't care about how you did on your internal medicine rotation. It's really important. It's your foundational adult medicine skills and knowledge. So it's probably the most widely applicable, the most important shelf and rotation that we do. And maybe that's arguable, but that's what I've heard. That's, the general consensus as far as I'm aware. Also, a couple of bonus miscellaneous thoughts at the end of the video, so stick around to the end. So as far as the environments that I was working, I had 2 weeks on community ambulatory clinic, and then I had 1 week on nephrology. That was my subspecialty. We were given the choice to choose between several different subspecialties. I chose nephrology, partially because I hate myself, but also because I know that nephrology is a topic that I struggle with consistently. I just has always been hard for the information, nephrology related stuff, to stick in my brain long term. So I figured, okay, I'll be forced to study it and really get it ingrained for the shelf, because I gotta know that stuff. After that, I had a week of nights on inpatient hospital nights. And then my last 4 weeks were inpatient hospital floors, the day shifts, because I had a week of nights and then I went into 4 weeks of day. As far as the hours go, oh my God, hours were significantly better than my surgery rotation, which I had immediately before my internal medicine rotation. If you haven't seen my surgery recap video, go watch it. I'll link it up above here. But man, the hours on IM were so much better. It was 7 to, yeah, it kind of depends on the day, early afternoon. Sometimes we'd get out a little early, kind of early would be 1-ish, but at the latest 4. Sometimes we had long call, which would make it a 10 to 12 hour day, but usually we're talking 6 to 8 hour day. One thing that was kind of annoying was very random days off. We were just random, a random Thursday, Tuesday. There, weekends, you may or may not be working. You have a 50-50 shot of working weekends or not. It's just how the schedule pans out for you. And moving on to the content of the rotation. Internal medicine covers all of adult medicine, right? So that is a huge breadth of information. I went into the rotation expecting that, okay, there's gonna be a lot of material to cover, tons of practice questions to do to cover all of the, subspecialties within IM and all the general IM stuff and all the preventive stuff and the blah, blah, blah. Well, it was even more broad than I thought. And honestly, I was so glad that I'd done the majority of my core third year rotations before doing IM. I feel like I had a pretty decent head start on a big chunk of the IM content. So a lot of it was stuff I was already familiar with, had already previously reviewed. I wasn't relearning all over again from first year. It was already borderline overwhelming for me, having done almost all of my core third year rotations and having reviewed a ton already. Still, it was a lot. So I don't know how people do that as their first rotation in third year. So then moving on to things that I saw, literally take your pick of anything in adult medicine. If I tried to list out actually everything that I saw, it would take me 20 minutes just to list it all out. So I'm gonna just go through highlights. We had a guy who came in with a pretty severe infection, and we cultured, blood culture, came back with this really out-of-pocket bacteria. I'd never heard of it before, and it's I'm gonna mispronounce. Let me read it so that I don't mess it up. It's Bladia extructa. Yeah, I don't know either. And we were like, what is this? How do we treat this? And infectious disease, we're like, move over. We're like, yeah, have at it. Luckily the guy was okay, but man, for a while there it was kind of touch and go. I had a really cool attending at one point on floors who was very into like, oh, this person has, you know, this finding here, come here, you know, and would like get me right in there. Not just tell me about it, but like here. And one patient that we had a hypertrophic obstructive cardiomyopathy. And it has a very specific exam finding that differentiates it from other similar sounding and appearing heart problems. She goes, okay, I'm gonna find the spot, best spot. And she's like, okay, our student is gonna come over and you're gonna do this, okay? And it's like, you have to do this Valsalva maneuver, you like bear down. And in this particular heart condition, that changes the sound that, like the heart sounds that you're listening to with the stethoscope. And you read about it, but this was the first time that I'd ever gotten to like hear it. And it was so obvious. It was really cool. And so that was like on my second day on floors. A really cool experience to just kind of get a very like stick in your brain context, because for those who are currently med students, for a lot of us, it's kind of difficult to remember like what maneuvers make certain murmurs sound louder or softer. Now, anytime I get a question about hypertrophic obstructive cardiomyopathy, I'm not gonna get that wrong because I remember this guy. And we had someone with Behçet's syndrome, which is pretty rare, but that's actually the second time that I've come across Behçet's in a year. So we actually had 2 people on my month on floors that came in with a mixed kind of like GCA, giant cell arteritis / central retinal artery occlusion presentation. And I was like, is this normal? I did it. And little did I know until, you know, having these patients that they can actually cause each other. I thought they were more separate entities, but they're not. And very classic, like, you know, painless, one eye vision loss, and then giving like the craziest dose of steroids you've ever seen. The intern was like, oh, is this right? This is a lot. And I'm like, I'm pretty sure. And then we checked the senior, you're like, yeah, it seems like a lot, but you gotta do it. And yeah, anyway, so one of them turned out okay. The other one was probably gonna be blind in that eye for forever because they left it and didn't come to the hospital for like 48 hours. But at least one of them had a good outcome. Saw someone with hypothyroid myxedema crisis. That was wild. She was young too. And then on my nephrology week, and you know, nephrologists just, I mean, hyponatremia is their thing and they love talking about it. Well, somebody came in with hyponatremia with sodium level of 110, okay? And to put that into perspective, anything under 130 is considered, you know, hyponatremia. 110 is like, this lady was like mostly all there. And we're like, how are you like this? You should be like, I don't know, seizing, comatose, something. And then we come to figure out, we're like, oh my goodness, because we take, you know, more and more detailed history. Family comes in, we're like, okay, getting the story. So it turns out that for a few weeks beforehand, before coming into the hospital, she'd been like kind of not feeling super great, coughing maybe a little bit, but nothing that concerned her. And so we were like, okay, well, you know, lung issues, lung infections can exacerbate or cause a little bit of hyponatremia. So get a chest x-ray, what do you know? She's got some little infiltrates consistent with atypical pneumonia. Yeah, she's also taking a medication that could lower sodium levels. So that in conjunction with this walking, you know, atypical pneumonia, poof, SIADH picture, syndrome of inappropriate ADH secretion. And we're like, oh my goodness, like girl, yay, we have a treatable thing for this. So, you know, treat you, change you to a different medication. This should never happen again. Very like a satisfying case where just like things worked and the picture made sense and it was, because sometimes you like, people come in and you're just like, well, we think maybe, I don't know. But in this case, it was cool. And we found something new and the nephrologist was loving it because it was all hyponatremia and SIADH and stuff, whatever. It was great. Now this next case is one that I was probably the most proud of. This guy comes in, he's like, oh, I've been having headaches, and you know, okay, can you tell me more about the headaches? Okay, they're like mostly just like on this side, and they'll just like come out of nowhere. Like it's not, well, you know, you're exerting yourself or anything. No. It's just like come on out of nowhere. Is it always on the one side? Yeah. Can you point to like where it is? He's like, yeah, it's just like it's behind my eyes. Like, behind your eyes. Okay. Do you have any light sensitivity with it? No, not really. Do you ever get nauseous when it comes out? No, not really. So we're thinking like, no, probably not so much a migraine picture, although he has a history of migraines. And he's like, no, this is different though, I think. And so then I asked him like, okay, you know, are we ruling stuff out? Then I was like, wait, do you tear up when the headaches come on? And he's like, actually, yeah, like every time. It's like the sharp stabbing and just like, I was like tearing uncontrollably. And I'm like, do you currently smoke? And he's like, yeah, I do like pack a day. This sounds a lot like a cluster headache. And he's like, a cluster headache? What is that? I was like, yes, you know, we predominantly find it in men about your age with, you know, specifically kind of right behind the eyes, sharp pain, comes out of nowhere with tearing, and in people who smoke. And he's like, oh, whoa, that's crazy. I'm like, yeah. So this is what I'm thinking right now, but let's get the doctor in here to see, double check. And the attending goes in to see them. And lo and behold, he's like, yeah, totally agree. It sounds like a cluster. He's like, I haven't seen a cluster in a long time. And he's like, good job. I'm like crying happy tears. It's like the first time where you feel like, oh, I do know something. I know a couple of things and I can put some pieces together. This guy was luckily like a textbook case, right? Absolutely textbook case. But it's still a cool feeling to like walk in there, blank slate. You have no idea what this guy's in here for. All you know is that he has a history of migraines. He hasn't been seen in years. And then you just go and figure it out. And you end up with the right answer. I think it was just a really nice feeling. Kind of proud of myself, Because most of the time as a med student, I feel really dumb. If I'm in clinical scenarios in the hospital, I'm just constantly feeling stupid because there's so much that I still don't know. And no matter how much I study, I feel like there's always going to be things that just like go right over my head, like things that I should have known, but like didn't. And I'm like, am I ever gonna feel like I know enough or that I'm gonna be a good doctor or like good at what I do? Like it just feels like you'll never get there. And so for just a short time period with that one patient, it was just nice to have a little bit of confidence in myself for, a split second, like, hey, I'm getting somewhere. We're not there yet, but I'm learning and things are clicking and it's a slow process, but we're getting there. And to finish up the rest of the highlights really quick here, bunch of different cancers, bunch of different arrhythmias, encephalopathies, seizures, so much congestive heart failure. Oh my gosh, everyone has congestive heart failure. And, obviously hyperlipidemia, diabetes, all that super common. Tons of stroke workups, myocardial infarction, aka heart attack. And also I was kind of surprised by the number of what I would call like question mark patients, mystery patients. It's like they're here and something is off, but the picture is not making sense, So there's not like a definitive, this is what's wrong with you, let's treat it this way and get you out. A lot of them are just like, okay, something's up and we can like manage symptoms, but we don't have a definitive diagnosis. We can't pin down what it is. So we just kind of have to treat you symptomatically until you're okay enough to be discharged from the hospital, And I'm like, it's just very frustrating. This kind of patients are very frustrating. Everyone's much happier when patients are clear cut, right? The things that I did were obviously, as I've kind of described, is definitely not very procedural. The most procedural it would get would be like if I followed a patient down to IR suite, if they were getting an IR procedure done or something, I would do that. But that's just because I'm interested in IR, right? So then I would go down, escort them back up, and that's about all I get. It was more just seeing patients, writing up the notes, presenting patients on rounds to different attendings, putting together also their like progress notes and their hospital discharges and lots of paperwork, unfortunately, but it is what it is in medicine these days, I guess. Okay, now for the types of people that go into IM. Very interesting to me how almost across the board, big time golden retriever energy in most IM people. I thought it was adorable. It was really fun, really cute, very nice people generally overall. Or maybe like Australian Shepherd. That might be more accurate because they're constantly like herding cats, basically, with like all the specialists and the patients and managing everything that a patient needs in order to get care in a hospital and get out of the hospital. So I think, yeah, maybe Australian Shepherd energy would be more accurate. Super friendly, loved and appreciated by just about everybody. And then it makes sense because like on the flip side, I would think of like surgery as black cat energy. There's like the golden retriever, black cat. Yeah, I feel like that's exactly what happened. So let's go over how I studied for the shelf, because again, like I said, very important shelf. This is very foundational for your medical knowledge base, right? So if you watched any of my previous videos, you know that the kind of core of my study strategy regarding shelf studying is UWorld and Anki, with a couple of supplements. It included online med ed also for a while, but then they recently made it not free anymore, and they're kind of charging a small fortune for online med ed videos now. So I have disowned them, and I'm not paying for that. There were enough like errors in the videos to like keep track of, and while you're watching the video, then you have to go read all the errata and kind of go back. Like, it was just a pain. So I was like, that's not worth it. Like, if they were free, yeah, a few of the videos were high quality for free, but I'm not gonna pay however much they're asking me to pay. And honestly, my studying and shelf scores have not suffered. Don't be mad at me, OME, if you watch this. Before starting UWorld though, for IM, I did AMBOSS. A little bit of AMBOSS, okay, 25-ish questions a day for the first couple of weeks to warm up to IM content. So I did AMBOSS 25 a day for the first 2 weeks, and then transitioned to UWorld, and UWorld I did like 25 to 30 a day for the rest of the time. And then a few days before the IM shelf exam, I did as many NBME practice tests as I could. Okay, I think I did 3. I think I did 3 this time around. And because of the amount of material with the IM stuff, I actually read a textbook for the first time. First time! Yeah, it was Step Up to Medicine, in addition to Anki and practice questions, of course. Because with Anki and practice questions, you're putting together and memorizing little bits of information. But it was recommended to me to use a textbook sometimes to get a big picture, right? Because all these pieces fit into a big picture. And if you don't have the big picture, a lot of that little stuff isn't gonna stick as well. Contextualizing in a different way helps things stick more, right? And I recognize in myself, like, yeah, Anki is great and I work really well with it, but sometimes when it comes to this much content, you need a broad overview resource to really bring things together and make things stick long term when you have so much to remember. So, and I found it really helpful actually. I didn't read the whole book, no. I just like picked and chose like different sections that I needed more help with, that I had trouble remembering big picture stuff on, and actually I feel like it did help a lot. So I would definitely recommend that for all you Anki heads out there and people who generally don't like reading the textbooks. Maybe give it a go for IM. Give it a shot. If it doesn't work, it doesn't work, but worth a shot. Anyway, so moving on to a couple of miscellaneous thoughts here at the end about, observations about the rotation as a whole and takeaways. Unfortunately, on IM, I had a close-up view. I got to see a lot more of like the nitty-gritty, day-to-day management of patients in a hospital, obviously. And unfortunately, there are a lot of inefficiencies and very frustrating holdups in patient care, often I've observed caused by insurance problems. I wasn't even the one that had to directly deal with the worst of it, right? And I don't have full responsibility over the patients I follow. And it was still so disheartening. I always laughed, like when patients are like, you just want to keep me here for money. It's like, are you kidding me? All residents and attendings want to do is treat and get people out of the hospital as quickly and efficiently as possible. Most of the time, the holdup is some like logistical issue, or we're waiting on imaging, or we're waiting on a consult from this place or the other place, or we're waiting on placement for SAR or psych or whatever. There are a lot of things that are just inefficient. And so often it feels like the healthcare system priorities as a business, because let's be for real, that's what it is. It is a business. Do not complement or line up well with high quality care. So there were some days where I was like tearing my hair out. I was like, what is this system that we're in, and why do we allow it to be this way? A lot of different reasons. But in my opinion, a lot of it is because the residents and attendings are overworked and they're not the ones that are in administration as much. And if they were, I think things might be a little different, and that's a whole nother soapbox. But it was just at times extremely frustrating to see how the system did not work in favor of good patient care. Wrapping up now on a more positive note, I really did enjoy the increased sense of ownership that the patients I saw were more like they were my patients, right? That was a really cool feeling. I can understand how people are drawn to specialties like internal medicine and family medicine who they're their patients, right? Definitely a different feel from previous rotations I've been on. If this style of recap was helpful for you, let me know down in the comments, and while you're down there, please remember to hit subscribe, share with your medically inclined friends and family. If you'd rather just hear stories, also let me know. Happy to do that as well. I just want to give people what they want for upcoming rotation videos. My next one will be pediatrics, and I probably won't be able to get that one out until after I take step 2. I'm taking step 2 CK at the end of June. So wish me luck, and I will get the pediatrics rotation one out as soon as I can after that is over. If you've already done this rotation, please give me and anyone watching your best advice down in the comments. I'm really scared actually, because kids are cute, but their parents scare me, right? So any advice will be very much appreciated. All right, thank you so much for watching. Have an amazing rest of your day, and I'll catch you next time.